The medic's hands are shaking as he kneels in the mud of Normandy Beach. June 6th, 1944. D-Day. Around him, the sounds of artillery fire and screaming blend into a nightmare symphony. In front of him, a 19-year-old soldier from Iowa clutches his shattered leg, his face white as paper, teeth clenched so hard they might break. The medic reaches for the small syringe in his kit, the morphine. Every combat medic carries them, little tubes with attached needles, like toothpaste tubes designed to save lives. He's been trained for this exact moment. Pain management in the field. He jabs the needle into the soldier's thigh and squeezes. Relief floods the young man's face almost immediately. The screaming stops. His breathing slows. Thank God, the medic thinks. He tags the soldier's collar with an M and moves to the next casualty. 3 hours later, he returns to check on the Iowa soldier. The kid isn't breathing. His lips are blue. His chest is still. And there are 5 more just like him scattered across this 50-yard stretch of blood-soaked sand, all with morphine syringes pinned to their collars. All dead. But they shouldn't be dead. Their wounds, they should have survived those wounds. The medic stares at the empty syringe still clutched in his hand, and a horrible thought begins to form. On this episode, we're covering one of the most tragic medical disasters in military history. A story about how American doctors, during World War II, thought they'd found the perfect battlefield painkiller. Something portable, fast-acting, and powerful enough to help wounded soldiers survive the hell of combat. Instead, they accidentally created a crisis that killed hundreds, maybe thousands of soldiers who should have lived. And the worst part, the very thing meant to save them was the thing that killed them. This is the story of morphine in World War II, and how good intentions led to one of the deadliest mistakes in combat medicine. Let's go back to 1940. The United States isn't in the war yet, but military planners are watching what's happening in Europe, and they're preparing. They're studying reports from the front lines, and one thing becomes crystal clear. Pain management is a massive problem. In World War I, injured soldiers often had to wait hours or even days for pain relief. Morphine existed, but it came in glass vials that had to be drawn up into syringes. In the chaos of battle, with muddy trenches and shaking hands, this system was a nightmare. Vials broke, syringes got contaminated. Dosing was inconsistent. So American pharmaceutical companies and military doctors came together to create something revolutionary, the morphine syringe. Picture a small tube, about the size of a toothpaste tube, with a needle attached, and a wire loop to break the seal. Each one contained a pre-measured dose of morphine tartrate, either a quarter grain or a half grain. A medic could literally grab one, jab it through clothing directly into muscle, squeeze and deliver instant pain relief. No measuring, no vials, no mistakes. It was brilliant, revolutionary. In 1941, the Squibb Pharmaceutical Company began mass-producing them. Millions of syringes. Every combat medic would carry them. Every aid station would stock them. The instructions were simple. If a soldier is in severe pain from a wound, give them morphine. Write an M on their forehead or collar so the next medic knows they've been dosed. Transport them to the rear for surgery. By late 1942, when American forces were fighting in North Africa, morphine syringes were everywhere. They were saving lives. Soldiers who would have died from shock and pain were staying conscious long enough to reach field hospitals. The innovation was working. Or so everyone thought. The first warnings, 5 to 9:30. It's January 1943. Tunisia. The North African campaign is in full swing. A young army surgeon named Captain Howard E. Snyder is working at a field hospital about 10 miles behind the front lines. He's exhausted. They all are. The casualties have been pouring in for weeks. But Captain Snyder is starting to notice something weird. He's getting soldiers who arrive at the hospital already dead or dying from wounds that shouldn't be fatal. A leg injury, a shoulder wound, nothing that hit vital organs, nothing that caused massive bleeding. These soldiers should be in surgery right now, getting patched up, recovering. Instead, they're barely breathing when they arrive, and some are dead within minutes. At first, Snyder thinks it's shock. Maybe these soldiers lost more blood than the initial assessment suggested. But then, he starts checking the casualty tags. The M marked on their foreheads, the morphine syringes pinned to their uniforms. And he notices a pattern. The soldiers who got morphine on the battlefield, especially the ones who got it in cold weather, or the ones who got multiple doses. They're the ones arriving in respiratory distress, shallow breathing, blue lips, unconscious. And when Snyder examines them, their wounds don't match their condition. The injuries themselves aren't life-threatening, but their breathing keeps getting slower and slower, until it stops completely. Now, Snyder knows morphine can suppress breathing. That's in the medical textbooks. Morphine is an opioid. It acts on the brain's respiratory center. Too much morphine, and you stop breathing. But these soldiers are supposedly getting standard doses. Quarter grain. Half grain, at most. Doses that have been carefully calculated to relieve pain without causing respiratory depression. So what's going wrong? Snyder starts asking questions. He talks to the medics bringing in casualties. How long ago did you give the morphine? Where did you inject it? How cold was it outside? And slowly, piece by piece, the picture comes together. The deadly variable, 930 to 1500. Here's what nobody accounted for. Temperature. When a soldier gets wounded in combat, especially in cold weather, their body goes into shock. Blood vessels constrict. Blood flow to the extremities, arms, legs, muscles, slows way down. The body is trying to keep the vital organs alive by centralizing the blood supply. Now, imagine a medic injects morphine into that soldier's thigh muscle. In normal conditions, morphine injected into muscle gets absorbed into the bloodstream over about 20 to 30 minutes. It's a gradual process. The drug enters circulation, travels to the brain, binds to opioid receptors, and provides pain relief. The concentration builds slowly, which means the side effects, including respiratory depression, are manageable. But in a soldier in shock, in cold weather, with constricted blood vessels, that morphine just sits there in the muscle tissue. It's not getting absorbed, it's pooling. The medic sees the soldier is still in pain. The morphine isn't working, so what does the medic do? He gives another dose, maybe even a third dose. He's following his training. Relieve the pain. Now there are 2 or 3 doses of morphine sitting in that cold muscle tissue. Then the soldier gets evacuated. He's loaded onto a stretcher, put in an ambulance or a truck and transported to the field hospital. Along the way he gets warm. His body starts to come out of shock. Blood vessels dilate. Blood flow to the muscles increases. And suddenly, all at once, all that pooled morphine floods into his bloodstream. 2 or 3 doses, hitting the system simultaneously. In the medical world, this is called bolus dosing, and it's catastrophic. The soldier's brain is suddenly overwhelmed with opioids. The respiratory center shuts down. breathing stops. And unless someone recognizes what's happening and can intervene immediately, the soldier dies. Not from his wounds, from the medicine meant to save him. The growing crisis, 1500 to 2100. By mid-1943, reports are coming in from multiple theatres. North Africa, Sicily, Italy. Doctors are seeing the same pattern. Soldiers arriving in respiratory distress, or already dead, with multiple morphine syringes documented. Captain Snyder writes a report. Other military surgeons write reports. They send them up the chain of command. But here's the problem. This is the middle of World War II. The military has just spent millions of dollars manufacturing morphine syringes. They've distributed millions of them. They've trained every combat medic to use them. The entire battlefield pain management system is built around them. And now doctors are saying they might be killing people. The initial reaction from military brass is skepticism. Some officers think the doctors are exaggerating. Others think it's just a few isolated cases of medics making mistakes, giving too many doses, not following protocol. There's pushback, but the reports keep coming. At Anzio, during the brutal Italian campaign in early 1944, field hospitals are overwhelmed with soldiers in respiratory failure. The wounds are survivable. The morphine overdoses aren't. Medical officers start doing autopsies when possible. They're finding soldiers with therapeutic levels of morphine in their systems, not overdose levels based on what was administered. But the effects are the same as an overdose, because of how the drug was absorbed. And then there's another complicating factor that nobody anticipated: fear. Think about it from a medic's perspective. You're 20 years old. You've got maybe 8 weeks of medical training. You're in the middle of a battle. Artillery is exploding. Machine guns are firing. Your friend is lying in front of you with his leg torn open, screaming in agony. You give him morphine. You follow the protocol. You mark the M. But he's still screaming. The shock, the adrenaline, the sheer terror, sometimes it overpowers even morphine's effects. So, you give another dose, and maybe another, because you can't stand to see him suffering, and you've got a bag full of syringes, and your training said, relieve the pain. Nobody told you that in cold weather. In shock, you might be loading him with a lethal dose that just hasn't absorbed yet. By the time of the D-Day invasion in June 1944, military doctors know they have a crisis. But what can they do? They can't just stop using morphine. Soldiers in horrific pain can die from shock. The pain itself can kill. Morphine saves lives. When used correctly, it absolutely saves lives. Combat medics need pain management tools, but they also can't keep having soldiers die from respiratory depression. The solution becomes a frantic effort at re-education. New guidelines are issued. Use the minimum effective dose. Don't give multiple doses in cold weather. If possible, give morphine intravenously instead of intramuscularly. IV delivery means you can control the absorption rate. But here's the reality. These guidelines are almost impossible to follow in combat. A medic under fire, treating multiple casualties, doesn't have time to start IV lines. He doesn't have warm conditions. He can't monitor each patient continuously to see if the morphine is working. He gives the injection and moves to the next casualty. That's the reality of battlefield medicine. Some medical officers start advocating for a different approach. Smaller doses, more conservatively given. Quarter-grain syringes only, not half-grain. And the most controversial suggestion: when in doubt, undertreat rather than overtreat. Let the soldier stay in pain if it means he'll survive. You can imagine how that went over, telling medics to watch soldiers suffer, to hold back on pain relief, when they have the medicine right there in their hands. It's psychologically devastating. Some medics start improvising. They'll give a dose and then physically warm the injection site, rubbing it, trying to get circulation going slowly rather than all at once. Others start documenting not just whether they gave morphine, but exactly where they injected it, so hospital staff can monitor those sites. At aid stations closer to the front lines, some doctors start keeping nailorphine on hand, an early opioid antagonist that can reverse respiratory depression. But nalorphine is in short supply, it's not widely distributed, and it doesn't always work if the overdose is severe enough. The whole system is improvised, desperate, and deeply imperfect. As the war pushes into France in late 1944, the morphine crisis continues. The Battle of the Bulge in December 1944, one of the bloodiest battles in American military history, becomes a nightmare scenario. It's winter, Belgium and Germany. Freezing temperatures. Soldiers are fighting in snow and ice. The conditions are perfect for delayed morphine absorption. Casualties are massive. Medics are overwhelmed. And the deaths from respiratory depression spike again. There are heart-wrenching stories from this period. A medic named Thomas Hendricks from Pennsylvania keeps a journal. He writes about giving morphine to a soldier with a shrapnel wound, marking him, loading him onto a jeep for evacuation. 2 hours later, Hendricks sees that same soldier at the aid station, dead on arrival. The wound hadn't killed him. Hendricks's morphine had. He writes, "I keep asking myself what I should have done differently. Let him scream, let him suffer. But I was trained to help, and I helped him to death." Another report from a field surgeon describes treating more than 200 casualties over a 48-hour period during the bulge. Of those, 23 died not from their wounds, but from respiratory failure after morphine administration. 23 out of 200. That's more than 10%. And these numbers are just from one field hospital over 2 days. Multiply that across the entire European theatre, across all the battles from 1942 to 1945, and you start to grasp the scale of this tragedy. The worst part? Many of these deaths probably weren't recorded accurately. Death certificates would list combat injuries or died of wounds because, technically, the soldier was wounded in combat. The morphine contribution might be noted in the medical records, but it wasn't always highlighted. There was no systematic tracking, no official count. To this day, we don't know exactly how many American soldiers died from morphine-related respiratory depression in World War II. Some medical historians estimate hundreds. Others think it could be thousands. The one positive outcome of this crisis was that it forced military medicine to evolve rapidly. Doctors and researchers began studying opioid pharmacology in unprecedented detail. They started to understand the relationship between shock, temperature, absorption rates, and respiratory depression. This research would later influence how emergency medicine and anesthesiology developed as specialties. In late 1944 and early 1945, the military starts experimenting with alternative pain management strategies. They begin using smaller doses of morphine in combination with other medications. They develop better protocols for monitoring patients who've received morphine. They improve medic training to include more information about the risks. One innovation that emerges is the buddy system for morphine administration. Whenever possible, two medics would coordinate. One giving the injection, another staying with the patient to monitor breathing. If respiratory depression started, the monitoring medic could intervene immediately. The military also starts pushing pain management back from the front lines when possible. Instead of giving morphine immediately at the point of injury, some protocols called for rapid evacuation to aid stations where medical officers could administer pain relief in a controlled environment with monitoring equipment. But these solutions came too late for many soldiers. When the war ended in 1945, the US military conducted extensive reviews of battlefield medicine. The morphine crisis was one of the major topics. Medical officers compiled reports, analyzed data, and tried to figure out what had gone right and what had gone terribly wrong. The conclusions were sobering. Morphine syrettes had saved countless lives. Soldiers who would have died from shock and pain had survived because of rapid pain management in the field. The innovation was fundamentally sound, but the implementation had been flawed. Insufficient training, inadequate understanding of the pharmacology, no systems in place to prevent overdosing in cold weather or monitor patients after administration. Most significantly, the crisis revealed a fundamental tension in combat medicine that still exists today. The need to act quickly versus the need to act safely. In an emergency room, doctors have time to calculate doses, monitor vital signs, adjust treatment. On a battlefield, medics have seconds. They're under fire. They're terrified. They're watching people suffer. The pressure to do something, to help, is overwhelming. The lessons from World War II's morphine crisis would influence military medicine for decades. In the Korean War, medics received much more extensive training on opioid safety. In Vietnam, new pain management drugs were developed specifically to avoid some of morphine's respiratory depression effects. In modern combat medicine, medics carry multiple drug options and are trained extensively on the signs of opioid overdose. But perhaps the most important legacy is the recognition that sometimes the tool designed to save lives can become the thing that ends them. Not because the tool is bad, but because the circumstances of use are impossible to control. After the war, some medics carried the psychological burden of what had happened. Thomas Hendricks, the medic I mentioned earlier, never got over the soldiers he believed he'd killed with morphine. He became a physician after the war, specialized in anesthesiology, perhaps trying to master the drugs that had haunted him. According to his daughter's later account, he would sometimes wake up at night saying, "I was trying to help. I was just trying to help." The families of soldiers who died often never knew the full story. Death notifications would say, "died of wounds received in action," which was technically true, but it wasn't the complete truth. In recent years, as more medical records from World War II have been digitized and studied, researchers have begun to piece together a fuller picture of the morphine crisis. Some veterans' families have learned that their grandfathers or great-uncles may have died not from combat injuries, but from the treatment of those injuries. It's a complicated grief. The medics who administered the morphine were trying to save lives. They were following their training. They were doing their best in impossible circumstances, but the outcome was still a tragedy. The story of morphine in World War II is a reminder that medicine, especially emergency medicine, especially combat medicine, is never as simple as it seems. What works in a laboratory doesn't always work in the mud and chaos of a battlefield. The drugs that save lives can also take them, sometimes in ways we don't anticipate until it's too late. Today, naloxone, the opioid overdose reversal drug, is standard in combat medic kits and civilian ambulances. We have better training, better monitoring, better protocols. We understand opioid pharmacology in ways the doctors of 1944 never could have. But we learned those lessons at a terrible cost. Hundreds or thousands of young men who survived enemy fire, who should have gone home to their families, who should have lived long lives. They died because the medicine meant to save them killed them instead. And the medics who tried to help them carried that weight for the rest of their lives. If you found this story as fascinating and heartbreaking as I did, please hit that like button and subscribe to the channel. Make sure your notifications are turned on so you don't miss future episodes. Thank you so much for watching. And remember, the most important stories are often the ones we don't know. Until next time, I'll see you in the next one.